At the data, the people with right ventricular dysfunction in acute MIs, they die a lot, like half of the time. And that's not an acceptable number, right?
All right. Well, we have another great case presentation on a BiPella case by Dr. Chris Brown, head of complex coronary at Swedish Heart. Chris, what is up, bro?
Hey, man, good to see you. I got this case. I'm wondering what other people would do, see if they like what I did. We'll kind of go through it and we'll decide what you think. So here's a guy, 41. Okay, presents to the hospital, crushing chest pressure, but a lot of shortness of breath. Sort of had progressive worsening symptoms actually for maybe longer than is desirable, and then finally decided to come to the hospital. Ultimately found to have really poorly controlled type 2 diabetes and some other stuff, but they shot this angiogram here. I'm going to kind of walk you through it, and they said, okay, well, his right coronary is occluded, and then they said, well, his circ is occluded and his LAD looks terrible. And we think that all
41, man, that's
the
nuts.
occlusions are chronic. And so they went ahead and took all these pictures and said, well, he should get a cabbage, I guess, because this is all chronic, even though he kind of presented with acute crushing chest pressure. And you can see his inferior wall is pretty hypokinetic here. And the anterior wall still moves, and it makes you wonder, is this acute, is this chronic? And they shot this, and there was some thought that maybe there was a mechanical defect, although there isn't a mechanical defect, but they were concerned, and so they went ahead and placed a balloon pump and then sent him for surgical evaluation to fix a mechanical defect if there was one, which there wasn't, like I said on echo, and then to have perhaps a bypass surgery.
And what does EKG and enzymes do, Chris?
Well, that's the thing. So his EKG looks a lot more like a STEMI than it does a chronic problem, and his enzymes are they're only going up, and they're doing it at a subtle and somewhat insidious rate, which makes me concerned that he actually has an acute occlusion that has not been opened, because when you don't reperfuse, you don't wash out the troponin quickly, so you never get to the really high troponin number quickly. It slowly builds and will continue on and on and on, because you need blood flow to go past the dead tissue to strip the troponin into the actual bloodstream. And so you can kind of see here inferior wall hypokinesis. Anterior wall looks like it's doing okay. And so he was looking pretty bad, and he has a swan in. And so I came in and they said, hey, look, this guy has primary RV failure right now. His LV is also really bad. EF's 20, 25%, but his RV, his PAPI is 0.6. And we are in a bad way, and the balloon pump is not enough. And there's no mechanical defect, and what do you think? And I said, I got to be honest with you, I think that's an acute right coronary, and I think it's now been 14 hours, which is not ideal, and I think that's why you have right ventricular failure. And
and I didn't see collaterals on that initial angiogram.
I know, and that's
they
what
say
really
in dogs it takes 6 hours to make collaterals, so if you don't have collaterals, it's
Yeah, exactly. So I went ahead and said, well, let's at least give him right ventricular support. Okay, let's figure out what we're going to do. We got to get him at least RV support, and then you got to tell me what you want me to do. Do you want me to try and revascularize him if it's possible? And they said, look, he's in a really bad way. You got to do whatever you can. So we went ahead and placed an RP Flex. That's our right ventricular support device. That if we don't need oxygenation, RP Flex is so simple now, so easy to put in. We just went straight to that. His LV is so bad, and I said, well, let's get to work. He's massively in shock. His BiPella is not going to help, his balloon pump's not going to do enough. So we'll give him BiPella, and if that's not enough, we'll go to RV with 5.5. But at least while I'm working here, I got to have some ability to get some stuff done, because his index is 1.4, his lactate's climbing. And so I took this shot, I just said, look, we're going to take a backup guide. We're going to take a small low-gram tip-load polymer wire and a microcatheter, because as this clot gets organized, people will probe it with a workhorse and be like, oh, no, that's a CTO. And that's actually a mistake, because most of the time as clot gets organized, as we know, you need some polymer jacketed wire and normally a little bit of microcatheter support to kind of make it through, because it really does become more fibrinous and a lot more solid. And we learned a lot of that from the venous DVT stuff. You really have to kind of work to get through a DVT before you extract it. and the same is true in the coronary clot. So we actually got across this with a Xion Black and a microcatheter. We swapped
Oh, I
back to a
love that, dude.
workhorse.
Hey,
You
Chris,
know,
a couple questions on this
but
on the hemodynamic support side, because I think a lot of people would look at this and say, first of all, with the RP in place, do you do any sort of hemodynamic assessment to determine whether you need a left-sided support too, or
we do two things. So the first thing we do is we say, well, if the LV is good and it's just pure RV failure, then we normally don't think we need any left-sided support. In this case, what we did is we implanted the RP flex and we started to run it the best, at its highest level, and it started suctioning, and that tells you the LV isn't giving you any flow. We run an index, and the index was still abnormal and still below 2, and so we said, well, we definitely have to do this with further support. But we essentially waited and try to ramp the RP flex up, because you can't put it in and go directly onto full blast P9 anyway. You have to slowly ramp your RP flex when you put it in, but generally speaking, if the LV is adequate and you're not going to overwhelm it with the RP flex, then your index will increase to something that's 2.1, 2.2, 2.4, whatever it needs to be, and you won't suction the device at the higher P levels. When you start really suctioning at the higher P levels on the RP flex, it's because you don't have any left-sided flow. Now you're not like filling up the tank for the RP flex to work.
And do you have a target right atrial pressure just to determine the suction events are not due to volume depletion?
No,
I'm sure
the device will just suction or it won't.
Okay.
Like the actual RP flex will just tell you, it'll alarm. Just like, when you put an Impella in somebody and the EDP is too low, even when the EF is bad, although that's rare, it can happen, and then you start getting suction events at P8 or P9, and we don't see that as much anymore, because now when we do protected PCI, the Impellas go into auto mode when it starts, and so it'll spin at P6 automatically, and you don't even really think about it. You're like, oh, why is it only getting me 3.1 liters? And it's like, well, it's getting you exactly the most that it can without the device suctioning, essentially. So
Interesting. And then some people say there's obvious benefits to BiPella support in terms of unloading and just ease of use in the cath lab. Did you think about ECMO in this case? What are your thoughts on ECMO for biventricular support versus BiPella?
When we need oxygenation, we go ECMO plus a vent. Normally our vents here are Impella vents. I know a lot of people do septostomies, but our vents are typically Impella, and we do about 60 ECMO cases a year here at the VA ECMO, so pretty large. But we essentially, if we needed oxygenation, we wouldn't have probably used an RP. Obviously it can't oxygenate, so we wouldn't have used it. That's sort of our threshold to kind of like decide, because the ease of use of this is a lot better, and especially in the pure RV failure population, when we use the device and they can ambulate still, we really like that.
That makes a lot of sense.
You can obviously use a Protec if you want. I find that this is way less cumbersome in the patient's neck than the Protec is. Way less cumbersome for them. And so
essentially, like crashing and burning or need for oxygenation, you'll pull the trigger on ECMO.
Right.
And then for just kind of unloading biventricular failure, you like BiPella. Would that be a good summary of your approach?
Exactly. That's exactly right. And, again, we started this not even knowing we were going to put in an LV support device. We were like, well, his RV is the thing that's failing him the most here. If we can get flow across his RV into his LV, is it going to pick up? And it just didn't pick up enough.
Got it.
So, and then you're in a stepwise thing. And so, obviously his right coronary was acute, right? I mean, that is what it is. We were across it. We did what you would normally do, right? We fixed it. Made it look a lot better, hopefully. We get to the end here. Get you to the final picture.
And did you aspirate that, Chris? Because I think some of these late presenting STEMIs, sometimes the clot's so organized,
It's too hard. So we always take a CAT RX to it, but I find that in arterial clot in particular, but in any clot that's old, as you say, that hasn't they require bigger catheters, frankly. A CAT RX is just, it really can pull out the soft stuff in the acute STEMI, but even in a leg, an old clot that's embolized from like the atrium to the leg, you have to use you take a Cat 7 or something down there, and it will not get it out, because it can't take the bullet. It needs like a bigger opening to work. So here we tried, it didn't really remove any clot, and so we just do our best to make sure that this is an IVUS direct stent, high pressure, no post dilation if able, with prolonged inflation to kind of trap that clot behind the stent if we can. The stents are so open-celled now that we use Megatrons or Xiences when we want to trap stuff, because the cells are closer together and it kind of is a tighter mesh network. If you use like an Onyx or a regular Synergy, the cells are so far apart that they're kind of just like a cheese grater to whatever you're trying to smash away. And you just get a bunch of protrusion of the clot and you get embolization, in my opinion. So that's why we
call
try
it caging the beast. You cage the beast,
Exactly.
You can suck it out or you can cage it. And that's
exactly. So we wanted to make sure this cage is good. And this is a late presenting thing. We don't know whether this is going to fix him, but he's 41, so we got to do whatever we can, because we're rapidly moving on to the next things. So he does okay and is better with regard to the right ventricle, but he still is not well with regard to the LV. And so we came back around. I'm trying to get it to open.
While you're pulling that up, Chris, what do you do for last remaining vessel? Because I know you do all the complex stuff, but what do you do for like last remaining vessel? Like you're working on a...
Depends on how bad the EF is. If the EF is below 35 single remaining conduit, we pretty much try and use a 5.5 in those patients if we can. Just because those people almost always are living by a thread, and the minute you inflate even a 2.5 balloon in the LAD or something, you're in such a bad way and you have no pulsatility, and even trying to recover at all is a bit much for a CP to tolerate. I find a 5.5 is enough to support somebody in like an actual sort of meaningful way, like almost complete support, if you will. And so we use a 5.5 in single remaining conduits if the EF is low. If the EF is somehow normal, which we do see with people with robust collaterals, we will use a CP, and those patients seem to do okay from that. But that's sort of our algorithm, if you will. We're always trying to figure out who it is that actually needs a 5.5, not just because the device costs a little bit more, but really more because it can be or does take surgical OR time for implantation. And I think as time progresses and as the devices get smaller and a 5-liter pump from becomes something that we can put in percutaneously, we'll move more to that. It'll probably increase in its use, but we have good surgeons who understand that while it's not their favorite surgery, it's really to help the patients, and they're willing to implant them when we need them beforehand. It's nice if the person's EDP is high and the EF is low in a single remaining conduit to get the device implanted the day or two beforehand anyway. They can still ambulate because it's from the axillary, and you can really unload their ventricle before you go cause a bunch of ischemic time. And I think that actually probably leads to better outcomes. That's sort of a bit of an anecdote, but that's what I would tell people to do if they have the opportunity.
Yeah, it's always shocking to me how much better the coronaries look once you get a little unloading going on. The coronary perfusion
so much better.
Picks up.
So anyway, this is he's diffusely diseased, and they said, look, he's still in really bad shock. You got to do something. And I was like, well, I mean, I'm about to break out, the 120 millimeters of stent here then. But, he's in extremis, and
you just got to leave a little room for the Lima, Chris. Right? We learned that in script.
Exactly. Well, and that's the thing is, in this case, honestly, what we're trying to do is get him out of shock to either optimize his A1C for the next 8 months, and ultimately, he'd probably end up getting a heart transplant sooner or later.
Yeah.
Or get him out of shock enough to where his renal function improves and he can go and have a durable LVAD as a bridge to transplant sort of thing, right? Because he's in a pretty tough situation. So, we fixed his LAD the best that we could.
That was great.
We got all the diagonals, we got the left main. It's about as good a result as we're going to get with that. You'll see us just do this left main here real quick. We always use Megatrons in the left main now.
Oh, that's so satisfying, dude. That looks great.
It is.
I love that when you lay it just at the ostomy of the LAD, so you can put a nice big boy in the left main. Yep. You don't have to worry about edge dissection. You can just kind of inflate it as big as you want. So I love that.
So we like that. We went and took a picture of the right again because, they're like, well, can you make sure that it didn't thrombose? And I was like, yeah, I don't think the right thrombosed, but sure. And this is just a picture of us getting, we put another swan in because the swan it was from the leg and it had clotted, and so we just put a new one in the neck. So anyway, he did okay. He recovered. His renal function improved to the point where the decision had to be made, can we wean him off of biventricular support, and we were able to wean him off of the right ventricular support, but the left ventricular support, as it came down, his renal function started to climb again, and so ultimately this was sort of his bridge to getting his LVAD, because he's got to get his hemoglobin A1C under control to get a transplant. But I think It's a good example of how much support you can need sometimes, even in a young person, and that we have the percutaneous tools to kind of provide that complete support now that we really didn't have before. You know, the prior Impella RP was it was just not easy to implant. It was not easy to utilize. This is such a dramatic improvement with regard to implantation quality that you know, we're really excited that it even exists, honestly.
Yeah. No, I think this is great because so many times these kind of slow slide, pseudo crashing and burning patients, you wait 45 minutes for the perfusionists to come in, you get the cannulas in, and by then you're in a bad place. And so I think having these tools readily available in the cath lab that you can put in very quickly is super helpful. Tell me a little bit about management. So you send this guy back to the ICU. How do you manage? Because I think this is a concern for people when they think about BiPella. You know, I got to manage the RP and I got to manage the CP. Do you just put them both on auto? Like, what's the management strategy for leveraging, right ventricular and left ventricular support simultaneously?
So there are kind of two parts. The first part is, how do you manage the right ventricular support period, and then how do you manage it in combination with the left ventricular support, because that's a little bit of a dance. So really you just manage the right ventricular support by making sure you're not getting suctioning alarms and making sure that you don't have a low right atrial pressure, right? Once you start to unload the right ventricle, it may be that your right atrial pressure is nowhere near what you think it is because your filling pressures aren't as high as you thought they were. They were all just congested because the right ventricle was failing. And so from our standpoint, we just like to make sure that we're not getting suctioning, and then we're at least at P6. If we can be at P6 or higher, we feel like we're doing a pretty good job. But we want to get kind of as much unloading as possible. If you start to creep down into the lower P numbers, then I start to worry about whether or not you could get thrombosis, because it's a venous system, right? So it's slow flow anyway. And so we like to make sure that we stay above P6 if we can. And then when you talk about managing these things together, then it becomes a dance where you turn up the left side to turn up the right side. And if the right side's suctioning and the left side isn't high enough, you need to try and turn the left side up some more. And then if it starts to suction, then the right side needs to come up. And really you're trying to get both of them as high as you can to where you're providing the most amount of unloading that you can give to both sides, right? You're trying to get the highest cardiac output, and you're just balancing the suction events. You can't really use the auto function on the left side after 4 hours anyway, and so you go upstairs and you kind of got to guess as to what you're flowing at. If you started on auto and it says you're at 3.1, you're probably at P6. If it says you're at 3.7, you're probably at P8 or P9, and you kind of got to jump to that number and then kind of dial it around. And you'll get early suction alarms no matter what you do when you come out of auto. You just got to let that settle out for a minute and then figure out where you're headed with regard to balancing both of them.
And what do you target in terms of right atrial pressure in these folks, like 10?
Yeah, I mean, essentially, it's like anybody with pulmonary hypertension or right ventricular dysfunction. We're not looking for you to have a right atrial pressure of 3. The device wouldn't tolerate that anyway, but it needs to not be 22 anymore. So 8, 10, 12, sort of what you think of as kind of euvolemia in somebody with a right ventricular problem.
Got it. It'd be nice if there was a swan attached to the RP. You should talk to your...
I know. You have to put in your own swan. It is kind of annoying. And I use the left neck because double sticking the neck is fine, but it becomes a little bit annoying when you do the removal. Because when you remove the device, you can pre-close it if you want in the neck. We don't do that anymore. We just use a figure of 8. Because you have to put a figure or some sort of purse string suture to tighten up around the repositioning sheath in the neck anyway. And so we don't really use anything but that anymore. So we put that, we tighten it up around the sheath, and then when it's time to take the Impella out, we put another one on, not tight, cut the old one, take the whole Impella out, and then tighten up our new one, and that's how we get hemostasis and hold a minute or two of pressure. We used per closes before, but sometimes the per closes were interacting with the removal of the physical Impella, and it didn't cause a problem, but it made some people who had less experience with RP Flex feel a little uncomfortable when they were pulling it out. And so we just moved to not using it at all.
So you just do a figure of 8. That's what you typically do.
Yeah, figure of 8. Exactly.
Just make sure you don't grab a bite of the carotid when you do that, right?
Yeah, exactly. I don't think we have to dwell on this too much, but it is interesting to know how many people who have acute MI have right ventricular dysfunction. Of course, a lot of that is because a lot of STEMIs are RCAs. But it's also interesting that if you have right ventricular dysfunction, bad stuff happens, and I think it's because we underperform in treating right ventricular dysfunction, if I'm being honest with you. I mean, we don't recognize it soon enough. We let it dwindle or dwell, or kind of we sit on it hoping that it's going to get better. We don't think about unloading the right ventricle so we can actually really feed the left ventricle so you can actually perfuse your end organs. And so you have to be thoughtful about the fact that, a third of patients with AMI have right ventricular dysfunction. And a lot of those people do not do well if you don't do something about it. So I do think that if you have any hint or any concern that you have RV dysfunction, that it is important to make sure that you find a way or assess the right ventricle. I prefer the PAPI. There's lots of other ways to see if the RV isn't working well. A lot of them are echo based, and I just don't have the time for a full echo with all of that stuff when I need to make an immediate decision. And the PAPI, I think, represents, from a data standpoint at least, sort of our best marker of whether the RV is really failing or not. And that's what we use here.
And Chris, you just want to go over, just for people that aren't familiar with PAPI, what that number is and what?
Yeah, let me go to I think I have a slide for it here even. There's the PAPI.
I would go as far as saying it's not just that RV failure is underappreciated. I think just the use of a swan in these patients is underutilized.
Well, yeah, that's probably a better way to put it, honestly, if we're being honest. I think that's a much better way to put it. So these are just some of the ways that you can evaluate whether the right ventricle is having a problem. You can see this is like incredible, like just so many different things you could do. And it's like, well, I can't, this is too much, right? We all know what the cardiac index is about, and we all know that people's CVPs matter, but I think the PAPI gives you the best information. And if you look at like the ISHLD and like everybody who really thinks about like hearts that are failing, this is really their preferred metric too. It's the metric that was used in the National Cardiogenic Shock Initiative. It sort of, I think, is really the standard from my perspective. And it's pretty simple because you can do it on the fly in like 2 seconds, right? You take the systolic pressure from your PA minus the diastolic pressure, and you divide it by the right atrial pressure. And you can see how that's kind of, it's an intuitive thing. It's like, how good of a squeeze or bump in pressure can my RV generate based on how much preload or stretch in the Starling curve do I have based on the right atrial pressure. So as the right atrial pressure stretches that RV out, and as the pulse pressure of the right ventricle narrows, your PAPI goes down, and that's when you're really starting to have a problem. And that's why I think it makes intuitive sense, and I think it's just the easiest thing to get because you just get it right off your swan, and it takes you 2 seconds to calculate. A lot of this other stuff, like I said, fine, like you can try and get a TAPSI, but you got to get good images. The patient's not able to roll on their side, they're on their back, they have this, they have that. I just think that's too much, and I think it's just a lot easier to say, what's the PAPI, where are we at with our cardiac index, and what do we do next?
That makes sense. Yeah, no, I totally agree.
Yeah, and again, you can see sort of simple things to understand, but one thing that's worth noting is that when you have right ventricular dysfunction, you may not get your PAPI back up above 2, but I will tell you that with RP Flex, we have not had a problem getting anybody back above 2, honestly. So we've had a pretty good success with this. You can see in people post LVAD, they still have abnormal right ventricles. I mean, that makes sense. We sort of understand how bad the RV is in people with bad LVs, and when you put a permanent mechanical support device in the left, it's going to not overwhelm, but kind of overwhelm the right. So that's not unsurprising. But I just think it's important to recognize that at least the RP Flex for us has really been a game changer because of its ease of implantation and the fact that we're able to actually kind of treat these right ventricular failures that I don't want to say we were sitting on them, but we were under treating them for sure. We might still be under treating them, but we're working our hardest at trying to make sure that we have algorithms that make sense.
I mean, I think, Chris, I think a lot of us learned in fellowship that RV failure is an independent predictor of bad outcomes, but most of the time it just takes a couple days of keeping their preload up and maybe giving them some inotropes, and most of these patients get better. What's your response to that in terms of who to unload, who to kind of...
If you look at the data, the people with right ventricular dysfunction in acute MIs, they die a lot, like half of the time. And that's not an acceptable number, right? And that number is more along the lines of what you see in cardiogenic shock before the National Cardiogenic Shock Initiative, which very clearly took us from hey, you don't need to unload, you don't need mechanical support, you just need to get them by, to, oh, if we actually do all of these things, like, our number here is that 78% of acute MI cardiogenic shock live. So
That's amazing.
if you can, improve mortality by 30%, I think that's you have to like open your eyes to that. And I think that the RV is in that category of like, what can we do to like truly make headway? And the ventricle does get better a lot of times. The thing I will say is intuitively, if you take a ventricle that's under stress because it has not been perfused, then it gets reperfused. Now it has intramyocardial edema. It has reactive oxygen species everywhere. And then you ask to stress it out by giving inotropes to make something work harder. To me, that doesn't make any sense.
No, I totally agree. I always remember those MRI images of people on dobutamine looking at all the subendocardial ischemia you get from flogging the myocardial oxygen demand with inotropes. So I totally agree. I think unloading is a much more elegant approach to getting these patients through their acute illness.
Exactly. Well, anyway, thanks for looking at my case with me. Hopefully it was something people enjoy or people can think about, or it's thought-provoking. It was thought-provoking for me for lots of reasons, both from the first images of this is a CTO down to the acute right ventricular failure that I wouldn't have, I would have anticipated, I suppose, with the right coronary STEMI, but at the same time, the florid nature in such a young person for RV failure was eye-opening. So.
No, dude, honestly, I think I'm going to use more BiPella after seeing this. And I think, so if you're planning up front on biventricular support, do you always put the RP in first, or?
Yeah, so I do, because I don't find that the LV becomes as easily overwhelmed as the RV does. So we put them in pretty quickly together, so it's not like a huge time delay. But I have put in Impella CP and 5.5s in people with bad RVs and had them arrest, and mostly PEA arrest actually, because the RV does not tolerate strong perturbation. It's the same reason we don't intubate patients who have large pulmonary embolisms, because when you perturbate the right ventricular system, people die, essentially.
Yeah.
They just don't do that well. And so if we can start unloading the right ventricle and then get in the LV's, pump, we can do, I think, a lot better. And the LV is, it's just a much more robust structure. Even if the EF is bad, it is so much more robust than the right ventricle. It can tolerate you putting that RP flex in. And the thing is you're not going to be at max speed on the RP flex when you put it in anyway. You have to really start slow and ramp it up. So you're maybe at P5 or P6 before you ever, by the time you get the Impella for the left side in. So it's not really of a dramatic consequence, because you're nowhere near 4 liters of flow. By the time the left side gets in and you're working.
Got it. And what would you say, last question for me, what would you say is kind of the learning curve for this? For people that don't have BiPella experience, they've got heart failure docs, what would you say, like how many of these cases do you have to manage on the front end and back end to really feel comfortable using it as a biventricular support?
I think from an implantation standpoint, you have to implant this like maybe 2 or 3 times total, because you have to run into the issue where the way this gets implanted is you float the swan and then you put the 027 wire for the RP flex in. It's uniquely soft but uniquely stiff, and it will you use an 035 catheter to do it, like an 035 Berman, because a regular swan doesn't have a big enough port. So you use a Berman or an end hole balloon tip catheter. And
pigtails work great too.
The pigtail is fantastic. Not as well from the neck, but from the groin always. We're always pigtail from the groin for us. We have a large pulmonary embolism cohort, so that's something that we use from that standpoint. But it'll kick it out, and so you have to do one of those where it's going to kick it out, and then you got to swap to a different wire. I use a Silverway. We take a Silverway, switch to either a JR or a multi-purpose, and then put that wire in, and then the wire's deep. And you got to put this wire pretty deep into the pulmonary arteries vascular bed to really put this in, because you need to make a corner, especially in somebody with a big RA and a big RV. To make that corner, you do need the stiffer part of the Impella wire. But when you have the wire in a decent spot, which is not hard to get to once you figure out that you might need to switch to a catheter instead of just straight through the end hole balloon tip catheter, this device just flies in. And I was at an implantation course helping people implant these maybe a week ago or whatever. And I'll tell you, by the second one, everybody is like completely dialed in, and they're like, they can't believe how easy this thing is. So when it comes to managing it, I think, it doesn't have the same hemolysis properties because of its size. It's like interlumen size, as a malaligned CP can have, which if a CP is in a good position and the patient's hemoglobin is not 55, we don't really have hemolysis problems anymore. But this doesn't really have that anyway. So that part's not really a concern from my perspective. And then the things that I worry about or that I think about is like, how do I get this thing out, right? Because RV failure, like you said, it does take a good tincture of time. So you end up having to wean it pretty slowly, a lot slower than you can wean a left-sided Impella, frankly. And then you have to know that you can't stay down low for long. So you can wean it all the way down to P2, check some fix, check some lactates, spend 30 minutes there, but you really got to get it back up above P4 after that, just because you don't want the device to thrombose. So you do wean the patient down slowly, and then you can come down to the lower levels before you remove it, but you need to go back up. So I come down, we spend 30 minutes there, and our advanced heart failure guys will get a mixed venous. They'll get a lactate, they'll make sure everything else looks the way that they want, and then they'll ramp it back up, and then they'll call us and ask us to explant it. So,
got it. No, that's super helpful, dude. Well, this was a great case, great save. It's scary that he's 4 years younger than I am. I'm glad I have my
right.
But that was great, man. Appreciate it.
Awesome. Thanks, Joe.
All right, thanks, bud.
Bye-bye.